Okay, everybody, this is the really exciting how to and explanatory video for the FOPS and for neutropenic sepsis. So because of screen, the way we're filming it, we can't really see what's written on here if you can see me as well. So I'm going to stand to the side, but I do wave my arms around a lot when I talk. So if you see a hand going in and out of the shot, that would be me talking with my hands. Anyway, so we're going to get started. Here we go. We're going to do a little bit about what is broad terminology, really important that we all understand the terms that we're all using. What are neutrophils and why on earth do we keep on about them so much? A little bit about neutropenic sepsis versus febrile neutropenia. They're different, but do we care? And a few case studies I'll get you to have a think about, hopefully. So first of all, the terms. We often use these terms, but what we mean by these terms can be something quite different. So just a few minutes or a few seconds just to explain that. So neoadjuvant, this one here at the top, this is treatment prior to their definitive treatment. So before they have their treatment that we are hoping to cure them with, we give them some treatment. So this might be, we give them chemotherapy to shrink down their tumour so that we can maybe take a little bit less for a cosmetic purpose, or because it's going to abut something that's really important. So if we can shrink it down before that, we don't get too close to that important structure it's near. Adjuvant, they've had their curative approach treatment. Now, just in case there's any that have got out and got away, we're going to give them some treatment to mop them up. So in theory, these people here, these adjuvant people here, are cancer-free. Radical just means a curative approach. You won't hear us say that we've cured a person. You'd only ever hear us say that we have intended to cure a person. It is a curative intent, a radical approach. Only time can say if we've actually achieved that aim or not. Palliative is when the cancer is in multiple places. Not always, if somebody has cancer in multiple places, does that mean they're palliative. But if it's in multiple places, it's more likely that we can't get rid of it completely. We are not going to be able to do a curative approach. So for these people, it's about giving them treatment to hold and contain their disease as long as they are fit for it, they want it, and we've got treatment available for them. We will keep going with these approaches, or these palliative lines of treatment, until such a time as they don't want it. Now they could be in this palliative section for years. So these people, we could still want to go to ITU. We could still want you to phone critical care outreach, because actually they've got another 10 years left of lines of treatment that they could do very well with. When we have no more options, they're not fit enough for it or they don't want it, they are therefore best supportive care. And at this point we have no more oncological treatments we can give apart from radiotherapy, which we'll give up until the last 4 weeks of their life. Terminal is somebody who is in the last days to weeks of their life. You will not hear an oncologist say that somebody is terminal. Patients will say it about themselves, and they often mean anywhere from palliative down. So they might say, I'm terminal, but actually if you were to speak to us, we would say this person has maybe a life expectancy of 5 to 10 years. But for the patient, they see themselves as terminal. Second thing is we're very good at, over time, I suppose looking back, a lot of the anti-cancer treatments that we had were chemotherapy. So we all collectively often refer to anti-cancer treatments as chemotherapy. And actually that's not the case at all. Chemotherapy is one bit of the overarching umbrella that is systemic anti-cancer treatment. It is not all of them. There's loads of different types now that we use in different ways for different tumour types. Immunotherapy, monoclonal antibodies, hormones, lots more. Radiotherapy we're not really going to talk about. What I would say is that for febrile neutropenia and neutropenic sepsis is what you see in cytotoxic chemotherapy. You don't see it in the others. They may be neutropenic, but they're much less likely to become neutropenic and septic. So chemotherapy is one type of systemic anti-cancer treatment. So this is a NEUT. It's very exciting. It's a common NEUT, but that's not the sort of NEUT we're excited about. These are the NEUTs we're excited about. And why are we excited about them? We go on about them loads, and there's lots of other types of white cells, and we don't talk about them half so much. And the reason we're excited about them is because there's more of them, they tend to get there quite fast, and they gobble bacteria. So for that reason, we care about neutrophils? Next one, here we go. So we've done that, that's why. Do we treat sepsis any differently, neutropenic sepsis any differently to sepsis? Every time I do this chat, people have different ideas about whether we do or don't. Nurses might say, yes you do, because we isolate them. Well, that's true, we do treat them differently because we isolate them, but from our point of view with this, we treat them all with sepsis 6. Whether they're neutropenic sepsis or sepsis, they're all sepsis 6. So febrile neutropenia, much more common than neutropenic sepsis. Febrile neutropenia is they come in, they've got a fever, but they're not showing all the other signs of sepsis. However, we don't know which patients are going to become septic. A lot of them won't, but we don't know that, so we're going to treat them all as if they could be neutropenic sepsis, because that covers us and keeps all our patients safe. So this is really old pictures of what our bits of paper used to look like, that we used to document on neutropenic, when we'd give antibiotics for neutropenic sepsis. The key messages from this is you need 3 things to be able to give antibiotics in neutropenic sepsis. 1, they need to have had cytotoxic chemotherapy, so not any old anti-cancer drug, just cytotoxic chemotherapy in the last 6 weeks. They need to have turned up at the hospital, and they need to have a sign of infection. The sign of infection could be lots of different things. It could be that they got a chest infection, it could be they've got diarrhea, it could be they've got an inflamed throat and a tonsillitis, it could be lots of different things. But 3 things, that's all they need. It's a case study that is a really, really common presentation that we see all the time coming into ED and MAU. And so this person, if we go back to neoadjuvant, remember we talked about that, this person has had their first cycle of chemotherapy just a few days ago. So this person before that was a fit and healthy individual who didn't go to their doctor very much. They're 35 years old, they're not going to go very often, they're fit and healthy. They found a lump, they've been to their GP sent them to One Stop Shop, they've gone to One Stop Shop, they've said they found something unusual, they've taken a biopsy, a couple of days later they've got the result, the next week they're in MDT, and that same week they're having breast cancer treatment. They have gone from a fit and independent person to somebody having anti-cancer treatment in a very short space of time. They haven't got their head around it, they're now in with you, they've never been in hospital, they're scared out of their brain, they don't know what we're talking about, and all of this, does this mean that they don't get any more anti-cancer treatment? Does this mean I'm going to die of my cancer because I'm now in with this and you're not going to give me any? And they're scared. You don't have to remember all that, but I just want you to have it in the back of your mind when you see them, that actually there's more going on in their brains than that admission. It's how that admission fits into the whole system for them. Anyway, this person, obviously we're going to treat as neutropenic sepsis. We get these bloods back. This is a very common situation. They often don't have a huge CRP, but they're low. So this is somebody we might treat, and they look more like a febrile neutropenia. So we are going to give and activate the FUP for these people. So what the FUP? The FUP is the future use prescription. It's really great. So it is a future use prescription that has been made in clinic by a consultant who has seen that person and prescribed their systemic anti-cancer treatment. At the same time they've done that, when they know all their allergies, they've written a prescription for antibiotics, wafted it into a cloud on Millennium, ready for when, if they come in, that the nurse can activate it and safely give it to that person to decrease their chance of becoming neutropenic and septic. So it's great, but we're not really using them, which is a shame, because we could, and you can, and they're there for you. Not going to go through that, you can read that bit, you probably already have. So to activate it, you go to on the patient's power chart, and you look them up on power chart, and down the side here it says things like request meds care plan, documentation, drug chart summary. You click on the bit that says request meds care plan, then it will say future emergency antibiotic and suspect, and that's suspected neutropenic sepsis or suspected neutropenia, there it is, and you press activate. All you need to do then is sign it. You are not signing the prescription. The prescription is from a doctor who knows that patient and has seen them in clinic. You are activating a safe prescription that a consultant has already written. So then you just order for signature, there it is, and that's just showing the same bit. And then you refresh your screen and it will pop up on your drug chart. You are not giving them a whole heap of antibiotics. You are giving them one dose, which should tide them over and help them to decrease their chance of becoming unwell before a doctor sees them. When the doctor sees them, they may well decide that they don't want them to have antibiotics. They don't think this is an infection. Well, that's their prerogative. That's what they do. That's fine. Your job is to keep them safe before that time, and that's great. So you can do that, and then they can make a decision whether they continue that or not. You haven't done them any harm. Right, next one. This is a YouTube clip. This links you to Jess's video, which is the next video if you click on the other QR code. So I don't think we can link that to it now, but anyway, that's where it is, and that's the other QR code, and that's the 1-minute guide on how to do it. So, for the vast majority of people with neutropenic sepsis or neutropenic fever, we can turn them around within sort of 24 hours, 48 hours, and get them home. It doesn't delay their chemotherapy. The vast majority will continue on the dose schedule as is, as planned. We may give them a little bit more protective drug to stop them from becoming neutropenic in the future, but for a lot of them, we just continue and they get better and they go home. But we need to be prompt in our early management, and it has a huge effect to them overall. By the way, don't neutropenic diet. We never do in ED and MAU. You guys never do it, but you do see it sometimes in outlying wards. It's not a thing. We don't do it in oncology. It doesn't help. It changes the flora of their gut, can make them worse, so don't do that. Yeah, so most of them will go home, and that'll be great, and then they can come back and get on with their next cycle of treatment. So these are a few case studies. Just want you to have a little read. Have a little read. This is their sort of mental score when you hear the doctors say, can you remember 43 West Street? And count backwards from 20. It's that test that they're doing to try and work out somebody's cognition. So have a read through and then have a think, is this somebody that I would be happy to give an antibiotic to before they were seen by a doctor? Would I be happy after they were seen by a doctor? What are my thoughts on it? So there's no real right or wrong answers with these. A lot of people have differing opinions, and we've had many a debated discussion with different consultants and different nurses and different doctors around the trust, with different people having ideas about what they would and wouldn't do. For most people they would. If we look what our 3 criteria were, chemotherapy within the last 6 weeks, well, they've had that. A sign of sepsis, well, you could say that the fever would be a sign of sepsis. Important to note, neutrophils, when they go around gobbling up bacteria, they create heat. If you haven't got any, you may not create any heat. So you may be neutropenic and septic without having a temperature. So it's not the be all and end all, but it's helpful. So they've got a fever, they're a bit confused, they've had chemo and they've come into hospital. I think you could give them an antibiotic. The doctor could come along and they go, no, this person's got blah, 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 we're going to CT their head. Again, that's their prerogative. What you've done is you've said they've had chemo, they're confused, they've got a fever, I'm going to give them an antibiotic. Next one. So this one, again, lots of discussion with this one from lots of different people about whether people would or wouldn't. I think that we know that they've had chemotherapy, so cytotoxic chemotherapy within the last 7 days. That's number 1. Number 2, they're here because they've presented medically expected, so they're number 2, they're here. Number 3, do they have a sign of infection? Again, you can argue this, whether they've got a sign of infection. It could be we're giving them radiotherapy to their throat, it's giving them a really sore throat. It could be they've got esophagitis from their radiotherapy. It could be lots of different things. We don't know that, and that's for the doctor who comes to see them to have a look. But could it also be that they've got a sore throat because they've got an infection in their throat? And it could be, so you could give them an antibiotic. You're not doing wrong, you're not doing harm. Again, they might come along and cancel it. That's fine. That's what they do. We're keeping them safe. This one, would you give them antibiotics? So from a neutropenic sepsis point of view, they had radiotherapy. So radiotherapy is not cytotoxic chemotherapy. So from that point of view, that doesn't count. That doesn't count as one of the things that could give you. But I've had several nurses that are hot on it, and I'm sure that's exactly what you are, that says actually they trigger on their respiratory and their tachycardia for moderate under the sepsis. So even though they're not neutropenic sepsis, they could trigger just under the sepsis protocol. So you could have a look at it from that point of view. Next one. So this one is quite tricky, and I think often we struggle to recognise diarrhoea as potentially infective, but actually with our neutropenic sepsis patients there can be particular problems that they can have with their guts, particularly if they are neutropenic, and they can get very, very sick. So I previously, back in the day, would have struggled with giving antibiotics to a patient that came in that just had diarrhoea, because I'd be like, well, it's their chemo, don't need to give them antibiotics. But actually, if they're neutropenic, they can get very, very, very sick. They get a thing called typhlitis, which is an inflammation in their cecum, isn't it? So I would give antibiotics, and I think that you can class diarrhoea. Again, we're giving them one dose, and you can stop it afterwards. So I think for this person, she's had chemotherapy, they've got diarrhoea, and the chemotherapy was 7 days ago, and I would. It isn't something that most people would feel comfortable with, but I want you to know that you can, and you can feel comfortable with it, and you've not done them harm, and in fact you have helped them by giving them an antibiotic if indeed they do have this condition that could make them very, very sick. Last one, would you give this person antibiotics? So most of you are probably screaming at your screen right now going, yes, we'd give antibiotics, of course we would, it's really obvious. So this is the one, these are the patients that we are really good at recognising as neutropenic sepsis. We're really good at recognising a chest source as being a source of infection. What we struggle with is that anything else can be. And actually, if you look at the literature, the vast majority of people that turn up in the literature, and indeed when you do an audit of the patients that come here, the vast majority of them have really vague symptoms, and then they have neutropenic sepsis. So I think you don't need to have an absolute ironclad source of infection. A lot of them, the symptoms are quite mild and quite tricky, and quite gentle. So if you've got a suspicion that it could be, you've got a FUP, they've had chemotherapy in the last 6 weeks, they're in there seeing you, give the antibiotic. You're not going to harm them, you're going to help them, you're going to start treatment early. The doctor, whoever comes and sees them, can change that. That's their shout. But you've done what you can first. So crack on, peeps. And that's it, really. Thank you.